Hello, everyone. My name is Brittney Murray. I'm a genetic counselor with the Hopkins ARVC program and Center for Inherited Heart Disease. And I'm going to be walking you through just a basic presentation today of the very beginning of just the basics of ARVC. This is very helpful for especially newly diagnosed individuals or family members who are trying to learn more. But I also have patients that tell me every year that they listen to this similar talk and they learn something new that they may have forgotten. So it's a good review for everyone as well. As always, I'm always happy to answer questions, and I'll have my email at the end of the presentation. So we have a lot to get through to set the stage for the rest of the afternoon. So why don't we go ahead and get started? Let me share my slides with you, and you should be able to still see me over in the corner, but all the content will be on the slides. So like I said, this is just going to be kind of the ABCs, a very basic level of information. And it's an introduction to the terminology you'll hear a lot about today, arrhythmias and cardiomyopathy. So again, starting with the ABCs of ARVC, what is in a name? You may have heard many different forms of the name of ARVC, including ARVC, ARVD, and now you might even hear ACM or Arrhythmogenic Cardiomyopathy. And so what does that all mean? Well, largely, besides semantics, they mean similar or the same thing. So ARVC is the technical correct term. It's a cardiomyopathy or a heart muscle disease that in most cases affects the right ventricle. And the big thing that we worry about is that it's very arrhythmogenic or causes abnormal heart rhythms. ARVD or dysplasia was the first term used back in the 80s when this was first diagnosed, and they only saw the most severe cases. However, once we've learned more about this disease, we discovered that it's not dysplastic heart tissue. They weren't born this way, but it's a cardiomyopathy that develops over time. So ARVC is technically the correct term, although you'll hear all of the different terms used by your physicians and especially Dr. Hawkins as well. Now we're even moving towards calling it arrhythmogenic cardiomyopathy as well, to really try to bring in and highlight the fact that this disease can be biventricular, so both sides of the heart, and that sometimes it can be left dominant. And so the right ventricle being in the name can be sometimes a little bit confusing to people who don't see this a lot. So any of these terms could be correct. So as many of you may know, ARVC can present with palpitations, dizziness, passing out, which we call syncope, heart racing, that what we're looking for is ventricular tachycardia, which I'll talk more about later. And many of you may have presented with a sudden cardiac arrest caused by VF, or you may have sudden cardiac death in your family of people that have passed away. And even other people can present completely asymptomatically. So they have evidence of disease, but they don't necessarily have symptoms. The diagnosis is made based on trying to sort through the diagnostic criteria, which we'll go through, but there's a lot of other things that people are trying to rule out, such as coronary disease. Myocarditis is a huge mimic of ARVC. Inflammation of the heart is what that means. Cardiac sarcoidosis can be difficult to distinguish from ARVC. An idiopathic arrhythmia, which is just an irritable foci in your heart, or other inherited arrhythmia diseases or cardiomyopathies. So when you're going through the evaluation, they are going to try to do a lot of tests, like rule out coronary disease by doing a cardiac catheterization. And the myocarditis and sarcoidosis usually have very specific ECG and imaging patterns, but it can be difficult to distinguish between these unless you're in an expert center. So ARVD itself was first described in 1982 by Dr. Frank Marcus and his colleague, Dr. Guy Fontaine, and Dr. Fontaine and Dr. Marcus are here. Dr. Fontaine, unfortunately, recently passed away a few years ago, but Dr. Marcus is in his 90s, doing well, and has finally retired, and we really hope is enjoying life, but we do still communicate with him frequently. You'll see here Dr. Hawkins right here with them at a conference some years ago. So like I said, ARVC is made based on meeting a set of diagnostic criteria. So these criteria were first made in 1994 and then revised in 2010. The 2010 revision, which if you can believe it was 10 years ago now, made the imaging criteria more specific and included genetics. This really helped to diagnose more early ARVC and to try to limit the misdiagnoses based on MRI, which still happen to this day. We're even talking about trying to revise the diagnostic criteria again right now to try to incorporate more left-sided disease. So again, I always say that the diagnostic criteria are actually based on what we understand of the underlying pathobiology of the disease, and that's the desmosome. So this is a micrograph of actually the desmosome at the cell-to-cell level, the bolts, as I often call them, or the protein connectors in between your heart cells. So there it is. So this is a cartoon of that desmosome, and you'll see that these are kind of the different proteins that are holding the heart cells together. And all of the proteins of the desmosome have different names, and you'll see some of them down here. Some of you may even recognize these protein names because you may have a pathogenic variant in one of these genes that is the cause of your ARVC. So as I always say, that it's that weakness in those connections that then over time causes the breakdown, and then that connection gets replaced by scar. So when we talk about scar, we talk about this fibrofatty infiltration. But what it really is it's not just fat, it's more fibrosis and fat. And it's these big areas of scar in the heart muscle which are causing issues. One of the first things that we can see is it starts to affect the conduction of the heart. When the electricity is transmitted through those connections, it gets slowed down. So this is what a typical QRS complex or EKG heartbeat should look like, that you have the P wave QRS and then the T wave. And you'll see here in an ARVC patient EKG that the T waves are inverted. They're upside down, showing a repolarization abnormality of the conduction of the heart. We can also see, I often call a signal averaged ECG is almost like a high resolution ECG, where we average the signals and really try to see a spike of this delayed conduction. However, your signal average can be abnormal for a lot of reasons, and it's not necessarily specific to ARVC. And in our studies, we haven't seen any independent emphasis on independent prognostic or diagnostic factors with the signal average. And because of the number of false positives, we very rarely, if ever, do signal averages anymore in our diagnostic workup or even in following our patients. Oh, sorry about that again. So the big thing that we love to track and that we do spend a lot of time evaluating is PVCs. PVCs are premature ventricular contractions. They're extra heartbeats. And so they would look like this, a big spike in there in your heartbeat. PVCs, however, are tricky because they're normal in the general population. But in our ARVC patients, we're really worried if you have more than 500 in 24 hours. And then also, we really are using PVCs to track the likelihood for having more malignant arrhythmias. More malignant arrhythmias being ventricular tachycardia, or VT. VT is a too fast heart rate coming from the bottom of the heart or the ventricle. So tachycardia, ventricular tachycardia. VT in ARVC patients can come from two ways. One, it can be triggered often by adrenaline or catecholamines. And then the second can be reentrant, like this picture, when the electricity gets stuck in a scar and it's just kind of stuck there. And this can cause not enough blood to get out of your heart and can give you a lot of symptoms depending on the rate and speed of it, and it can cause you to get dizzy. This is what a VT would look like on an EKG. You can see the heart is going very fast and erratic. What we really worry about is when the heart goes into ventricular fibrillation. So the electricity isn't necessarily stuck, it's just quivering. It's not really having any electrical propagation at all. So no blood is really getting out of the heart. And this is what we worry about for our patients having cardiac arrests. So besides the electrical side of things, these breakdown of these connection bolts in between your heart cells also affect the heart muscle over time as well. And this can cause the heart muscle to not be held together as tightly as it should, and the muscle to bulge around the scar when it squeezes, because the scar is not stretchy like muscle. So you can see many of our patients have these what are called dyskinetic or akinetic segments. That means they're just not moving in line with the rest of the heart. And this is what they look like on imaging. If you do a biopsy, sometimes in ARVC, you can actually get some of that fibrofatty tissue and see the fatty infiltration as diagnostic for ARVC. However, this is very hit or miss, and ARVC is a patchy disease. And so because there's so many other good ways of diagnosis, and because it's very hit or miss whether you actually get a good sample or not, that we don't really do biopsies to diagnose ARVC anymore, because we have other better non-invasive ways. Genetics is another important piece of the diagnostic workup of ARVC, because about 60 to 70% of ARVC patients will have a pathogenic variant in one of the genes that we know provide the instructions for that whole desmosomal complex. So genetic testing can be a really helpful way to confirm a diagnosis, to give us some prognostic information, and to help us with information for family members. Now, I say current techniques will pick up a pathogenic variant in about 60 to 70% of cases. That means that there's a whole about 1/3 of patients who meet criteria for ARVC, and we do think have ARVC, that don't have a known pathogenic variant. That doesn't mean that ARVC isn't genetic. We still see it tracking in some families that don't have a pathogenic variant. It just means that we don't understand a lot about their underlying cause yet. Now, there are newer genetic testing techniques that can pick up on mutations that were missed on initial screening. So if you do not have an identified pathogenic variant and you have not had genetic testing since 2012, I would recommend repeat genetic testing. So if your genetic test report says sequencing only, or if you only had testing done through a company called Familion that only did sequencing, I would recommend repeat testing. Now, I say this every year, and I get a lot of questions, so I'll really clarify. If you have a pathogenic variant in your family, and you were tested for that pathogenic variant and you don't have it, in almost all cases, I would not recommend any repeat testing for you, because the likelihood that you have a second variant in your family is very low. So this is only if you have ARVC and we haven't figured out the cause of your ARVC yet, that you may want to check back in with me. So again, a lot of people ask me questions about genes versus protein, or they may say, I have the ARVC gene. Well, guess what? We all have the ARVC genes. I have PKP2, Dr. Calkins has PKP2. We all have a copy of PKP2. That's the gene, that's the actual instructions. What we look for is that, is there in the gene a variation or a misspelling that causes the protein to not be made correctly, which then causes the desmosome to be weaker than it should be. So do you have a pathogenic genetic variant versus just I have, quote unquote, the gene? So genetic testing then is a spell checker almost that looks for this variation or these misspellings or changes in the genes. Most of the labs now can do this testing via a saliva sample or a cheek swab. I very strongly recommend meeting with a genetic professional before you have genetic testing to make sure the testing is ordered properly and that you understand what the implications of that testing are. There are a lot of counselors that I know across the country who specialize in cardiac conditions, and I can hopefully try to hook you in with one of them. So who should get genetic testing? People who have clinical features of suspected or confirmed ARVC, and then parents, siblings, and children of someone who has a pathogenic variant can undergo testing for that specific variant known in the family. Again, if you have a known pathogenic variant that tracks in your family, it is unlikely that there is another pathogenic variant. I said unlikely, not impossible, but unlikely. So as long as it tracks with the disease in your family, and you can check with me, if you were negative for the family variant, I wouldn't recommend repeat testing. So again, this mutation is kind of the older term, or now we say a pathogenic variant is a change in the genetic information that causes the gene to make a non-working protein. And therefore, this is a risk factor to develop ARVC. It does not mean you necessarily have ARVC, and I'll talk a little bit about that. There are a lot of different types of variants, and we're really trying to figure out, based on the type of variant that there is, whether it is actually causing damage to the protein and causing your ARVC or not. Generally, big deletions or missing information are known to be pathogenic, but sometimes we have what are called uncertain significant variants, or variants that just substitute different building blocks of the protein, and we're trying to figure out if that actually impacts the protein or not. So you see these uncertain variants. I always use this silly analogy, is like if the protein building block of the desmosome is like a stack of Legos, is that variation like switching an orange Lego for a red Lego, and so it doesn't actually impact the protein structure at all? Or is it like switching a Lego for a Lincoln log, that even though these are two building blocks, they don't connect together? So this is the big evaluation that I'm always doing when I'm doing genetic testing, to try to understand if a variant is actually the cause of disease in a family. So you can nowadays, I always throw this in there, and do something called pre-implantation genetic testing. So this genetic test information can be used to gain information about whether potential pregnancies are at risk, or possibly even test embryos before they're implanted and make sure that the mutation is not passed on. This is a very invasive and very expensive process, and there's a lot of pros and cons to this process. So I would really recommend talking to myself or another genetic counselor extensively about this if you're thinking about different prenatal options, and whether passing on this pathogenic variant is something that makes sense for you and your family or not. All of that being said, I want you to hear it from me and from Dr. Calkins that for almost, above 90% of ARVC patients, pregnancy is safe and tolerated. And we have plenty of patients with ARVC who carry healthy pregnancies, and you're able to have children if that's something that you and your partner want. Again, I'm happy to talk to you and your family much more about this process, but if you hear it from me, at least hear it once, that pregnancy is not something that is contraindicated in most ARVC patients. So again, talking about passing this on and family history, one thing that is very confusing to a lot of people is that they don't understand how they could have a genetic heart problem when they don't necessarily have a family history of it. So sometimes family histories can look like this, that I have multiple people with heart disease and they carry the pathogenic variant, and then I have some people who just carry the pathogenic variant and don't necessarily have heart disease, but there's lots of people in the family that I follow. Other times, family histories, many times, in fact, over 50% of the time, family histories can look like this. So I have one person who presents and has ARVC and a pathogenic variant, and then I test lots of other people in the family, and they also carry the pathogenic variant, but have no evidence of disease whatsoever. And so it's a constant battle discussing with families how this is possible, that this is something that has been passed on, and some people develop it and some people don't. And we're really trying to understand a lot more about why that is. This is a concept called reduced penetrance. So current estimates are that only about 30 to 50% of variant carriers will go on to develop any disease. This is greatly modified by exercise, especially if you have a PKP2 mutation. We know that family members who exercise a lot, and exercise is a complicated discussion that I'm happy to discuss more with you about what I mean by exercise. But family members who do a lot of very strenuous endurance exercise, may have close to an 80% risk of developing disease. Whereas family members who don't exercise to that level have a much less strong risk of developing disease. Additionally, then we have other families where even if they all have the same exercise level, some develop it and some don't. So we know that there are genetic modifiers out there, so protective factors, which are protecting some people from developing disease or perhaps some other people, giving them a greater risk of developing disease. We're doing a lot of studies right now to try to better understand these genetic modifiers. And I know my colleague Cindy will talk to you in a couple presentations about a big study we're launching about that right now, and what you can do to help us better understand genetic modifiers. The most important thing for you to remember, however, is that even in the family with the same exact genetic variant, family members can have highly variable courses. Family history does not predict outcomes. So just if in the event that you have a family history of sudden death or sudden cardiac arrest, that does not mean that your risk is higher. And like I said, only about 50% of patients have any family history at all. So we're trying to understand more about exactly what I said about genetic modifiers and trying to predict clinical outcomes based on which underlying protein you have that isn't working correctly. The strongest evidence that we currently have is that desmoplakin or DSP variants are more likely to present left-sided. So they have their whole own host of individual problems and sometimes can be harder to diagnose because people aren't as used to seeing left-sided presentation. And then PKP2 variants, as I just said, are the strongest link with the exercise as a modifier that we know. So I'll go over this briefly, and I know that Dr. Calkins is going to talk a lot more about this, but now that you have ARVC and you have the diagnosis, well, now what do you do about it? So the 4 big hallmarks that Dr. Calkins and I talk about in management are arrhythmia management, preventing sudden death, preventing progression, and then family management. And we'll go through just very briefly a little bit on those because I know Dr. Calkins will talk a lot more about it. So when we're talking about preventing sudden death, one of the first things that we're talking about is who is at risk and at high enough risk to need an internal cardioverter defibrillator or an ICD. Not everyone with ARVC needs an ICD. And in fact, if you were just screening in a family, you are much lower risk to need an ICD and probably just need followed. So everything we're doing is trying to understand who is at high enough risk to need a defibrillator to prevent them from sudden death. And you can have the typical transvenous device that has a lead in your heart, or you can have this newer subcutaneous device that doesn't have any leads in your heart. And there are pros and cons to both. When we're talking about arrhythmia management, usually one of the first things that we're talking about is beta blockers. Beta blockers are really important because, like I said, these arrhythmias can be triggered by adrenaline. Beta blockers block adrenaline to the heart and reduce your risk of arrhythmias and have been shown to reduce sudden death. And people who beta blockers are not enough and antiarrhythmic medication isn't working or they have side effects to antiarrhythmic medication, we're usually talking about a catheter ablation, which is an invasive procedure to try to stop the areas where the electricity is almost getting stuck. So catheter ablation looks a little bit like this. Dr. Tandria will talk a lot more about it. It's an invasive procedure where catheters are put in the heart and then they're going and finding the areas of scar and almost putting up detours to try to help the electricity not get stuck in the scar and to create a very detailed map. And here is red of an actual patient of ours of where all the scar is. Another really important factor, and one thing that as medication and ablation are getting better and better at controlling arrhythmias that we are really focusing on, is how do we avoid structural heart progression? We don't want our patients going into heart failure if we solve all their arrhythmias. So all of the data that we have is that ARVC is very slowly progressive. That's why we like to use medications like ACE inhibitors that reduce the load on the heart and so make it easier to pump, and so your heart doesn't have to work as hard, and so the structural disease is slowed. And then exercise restriction is a really additional important part of reducing the progression of the disease as well. We'll go through, and Dr. Calkins will talk about a lot of our new data on how we're trying to prevent and better understand heart failure in our patients also. So I've talked a lot about exercise and exercise restriction. So you'll see if you look at the official guidelines that have been published for ARVC, that if you have ARVC, you can do class 1A athletics. which this is class 1A from the chart, is bowling, cricket, curling, golf, riflery, and they added yoga to the newest evaluation. Now, most of our patients will tell us that most of these activities are not what they want to do, not what they're used to do, and all, sound quite lame. And so this is where I really encourage you to talk to me, talk to Dr. Calkins, and we can talk a lot more about the spirit behind these guidelines and make an exercise plan for what you want to do and what is probably safe for you to do. It's incredibly individualized based on your testing and your mutation and your history. So it's not a one-size-fits-all prescription for everyone, and is usually a much longer conversation. But usually we can come to some sort of agreement for what is something that is safe for you, but still helps you maintain a higher quality of life. So again, I would encourage you to have a consult with us to discuss this further. And all of that really goes into, because what Dr. Calkins and Dr. Tannery and I are really trying to push is that we're making sure you're taking care of your whole self. We know that being active for many of our patients is really important to their quality of life. Patients with genetic heart disease have been shown to be at bigger risk for body image concerns, anxiety, depression, specific anxiety related to your ICD, difficulty adjustment. And then this is only more difficult when we often taking away your favorite coping mechanism, which is exercise. So I want to really just normalize these things and really encourage you that all of these things are very common and happen in many of our patients and are very, very important to address. I always say that managing your mental health is equally as important as managing your defibrillator or your medications or things like that. So I really want to make sure that you're not ignoring this piece of your management. So I have a very low threshold to really encourage you to meet with a therapist or a psychologist to try anxiety reducing techniques, meditation, other things, or in some cases, short-term medication, long-term medication. This can be really critical in your arrhythmia management as well. Meeting with a therapist or a psychologist is sometimes it's more of like a dating process often that we talk about. You might not click with the first person you meet. I'm happy to kind of consult with them and try to help them understand this disease. It's going to be a process to find someone who really gets you and that you feel comfortable with. So I'm happy to help you, but just please do realize that it's a process. And it's not like a quick fix Band-Aid, but it's a really important part of your management. And the reason of that is because we get into this vicious cycle. So the stress, everything from your diagnosis, it can lead to a lot of anxiety, lack of sleep, more stress, all of these things then biologically produce catecholamines or adrenaline and other hormones into your body. And then these hormones cause palpitations and PVCs. They may even trigger VT. And then you feel the PVCs and you become aware of your heart. And guess what? Feeling the PVCs and knowing they can be linked to VT make you more anxious and more stressed. So then you get stressed again. And then the whole cycle goes over and over and over again. So we talk a lot about trying to break this cycle. And it's a really important part of your management that I'm happy to help you try to sort out, but usually is a little bit of a longer ongoing discussion. One of the things that we've often presented on in our annual conferences and that has been shown to have a lot of help is something called mindfulness-based stress reduction. So this can be done through yoga, meditation, true MBSR courses, and a quick, easy fix is often even just something called box breathing. Box breathing has been shown to reduce stress hormones, calm your heart rate, and sometimes can help really breathe you out of an arrhythmia episode, or even at the most basic level, just calm your anxiety. And it's this box of inhaling, holding your breath, exhaling, holding your breath, and doing that over and over and over again for even just a few minutes until you can try to calm down your anxiety. So again, all of these pieces are really important parts of the management of ARVC and the whole patient and the whole family. If you have further questions, Crystal and I are more than happy to discuss things with you to try to get you on the right path or to get you set up for a consult is usually what's needed. We very strongly recommend even just a one-time second opinion consult. Myself, Dr. Tandrine, Dr. Calkins, Dr. Galotra, who sees all of our heart failure patients, and Dr. De La Uz, who sees all our pediatric patients, are available to see you and make specific medical recommendations for you and your family. So in the time of coronavirus, this has presented some challenges, but actually for our program has also opened a lot of doors. So we're still seeing tons and tons of patients in the clinic in person. However, telemedicine is a really great option for our patients. Most of the time, what is needed is just an overinterpretation of the testing that you've already had. We love telemedicine. It really helps us have a lot more access to a lot of more people around the country who we would no longer, or excuse me, we would normally not really have access to because they don't have the finances or the availability to come to Baltimore and to see us. So therefore, we really like telemedicine as a great option to talk through these things. However, telemedicine availability is not nationwide, unfortunately. Telemedicine availability is a state-based legal decision. So us at Hopkins are not making this decision, your insurance is not making this decision, your doctor is not making this decision. Every single state of the 50 states has different rules and regulations that say whether they will recognize or give a waiver or reciprocity for our out-of-state medical licenses to practice medicine across state lines. If you have questions about your state, you can email Crystal or I, and we can let you know as of now whether we have availability to do telemedicine with you or not. We do for a lot of states, but unfortunately for some states out there, they just won't legally let us do it. And that's unfortunately when you do have to come see us in person at Hopkins. But again, we're happy to talk you through this. In most cases, everything at Hopkins is very careful, very locked down. As long as you travel with care, there is really not a greater increased risk in coming in and getting your appropriate medical care. During the time of a global pandemic is not the time to be ignoring your routine medical care, because if you were to get COVID or something else like it, being not at your ideal best health is going to put you at greater risk. And it's also putting you at greater risk of advancing your disease by ignoring your routine medical care, because things could be progressing and you didn't know it. So we really encourage you not to put off your medical evaluations, and that we are happy to help you get safely evaluated if we can. There's lots of resources for information where you can learn more about the things that I've discussed today. There's our website, arvd.com. There's the SADS website, of course. If you have a very specific genetic variant in a gene called phospholamban, there's a conversation for you. Sorry about that. And a Facebook group as well. And that's all for the ABCs of ARVC, and I'll talk to you a little bit more.